Hi, I'm going to be discussing some of our recent case studies to show the WorkEsteem program that we deliver here at the Opus Centre. I first want to talk about a large public sector-based organisation. They are a logistics company with almost 65,000 workers all across Australia. We've worked with over 700 of their workers across 20 groups to deliver the program, and they came to us quite mature. They actually have some good language already around mental health. There's been mental health first aid training, they have wellbeing policies, wellbeing champions, but they wanted to make sure that they were doing best practice with psychosocial risk assessment and psychosocial hazard management. So we started by doing some awareness raising. We talked to as many staff who were going to be participating either directly or through webinars, letting them know about the reasons we're asking them to participate in the psychosocial risk assessment. We collect data using our psychosocial risk climate tool, PRC, and that captures the proactive and reactive climates within the organisation to protect workers' psychological health, keep workers safe from psychological harm, also some indicators on job demands and job resources. They did find that there were areas that were doing well. They did have a lot of resources supporting worker mental health directly. They also had some good communication and good collaboration. But for some of their groups, they needed to work on workers' ability to participate in the design of systems to create safe systems of work. Also in senior leader priority to demonstrate their priority for mental health in balance with productivity, as well as some leader action to attend to concerns for psychosocial hazards as they arise. Many of their groups also showed indicators for high levels of work pressure with high levels of cognitive demand, also high levels of emotional demand as well. After we did our risk assessment, we worked with key representatives across the groups who came together in a one-day workshop. We went through the results of their risk assessment. We interpreted those to understand why we might be seeing certain indicators within the context of their particular work groups. We asked their key representatives to prioritise factors based on their risk profile, to put down what they were already doing to reduce risk in relation to these factors, and to start thinking about some practical actions or strategies they could implement to enhance how they manage risk, how they manage these factors, and reduce that potential for harm. Some of the examples that they designed as controls were skip level meetings where seniors would come and talk to workers directly about how they wanted to see policy and procedure implemented to demonstrate that priority for mental health in balance with productivity. They put together some meeting courtesies, a bit of etiquette around how to have meetings. For instance, certain days, certain afternoons, Friday afternoons, try to make those meeting free. When you do book meetings, making them 50 minutes or 25 minutes so that there could be some recovery in between. Leaders also role modelled these strategies and continued to promote them. We had peer group sessions where wellbeing champions and team members came together to discuss how these strategies were working. Clearer resources around how to use the processes and procedures within their SharePoint so that people could access what they needed more directly. They provided some specific training. There was some training for a group that was managing high conflict personalities to enhance their skills in that area. They also brought their EAP on site and face-to-face on a more regular basis and promoted the use of that EAP so that people who were struggling would feel more confident to utilise that existing service. We provided consultation for a period of time with each of the groups to finalise their action plan. We also had some networking where we had representatives from each group come together to discuss, to whatever extent they felt comfortable, how their action plan was going, how the implementation was going, were there any barriers that we could support or address, and what was working, what were the facilitators, and we could share that with the other groups. We continued that process for approximately 6 months until the majority of actions had been implemented to a good extent. From the co-design and implementation of those action plans, we found significant reductions in risk across all of our indicators, and we found particular reduction for the indicators we were targeting. Things like workload and emotional demands and worker participation, leader action and senior priority. Some groups had a major shift going from a high risk for poor mental health, wellbeing and productivity outcomes to low risk. And some of the groups showed a significant increase in engagement, in productivity, in early health seeking behaviours. Also, they recorded a 10% reduction in unplanned leave. The good thing for me to hear was after the head of HR said that previously when they had been raising psychosocial factors, people weren't sure what to say. But now they had plenty of discussion and plenty of ideas for how to continue to control those risks into the future.